Welcome back to the deep dive. Today, we're jumping into something specific, but really important for anyone looking to solidify their medical knowledge,
Hmm.
especially if you're deep in MSRA revision right now. We're cracking open your notes, the ones you've shared, focusing on lacunar stroke.
That's right. These notes are, well, they're pretty comprehensive, covering all the key areas. Our goal today in this deep dive is to take this material and really, distill it.
You make it high yield.
Make it high yield, connect the dots, and hopefully make it stick for you.
Think of us as guides, yeah, helping you navigate these notes. We're going to unpack exactly what a lacunar stroke is, why it
What
happens.
it looks like.
Exactly. What you'd see, how it's diagnosed, managed, and, what the outlook is.
It's a journey through a very particular corner of cerebrovascular disease.
Okay, let's unpack this then. Starting right at the core, looking at your notes, how do they define it? What's the fundamental idea we need to grasp first?
Okay, so at its heart, a lacunar stroke is a specific type of ischemic stroke. Ischemic meaning, caused by lack of blood flow.
Right, a blockage.
But the crucial distinction your notes highlight
Yeah.
is which vessels are involved and where the damage happens in the brain.
So it's not just any old blockage.
Precisely. It's caused by the occlusion, the blockage of small, deep, penetrating arteries.
Ah, the tiny ones.
Yeah, these are the tiny vessels branching off the bigger arteries, diving deep into structures like the basal ganglia, thalamus, pons, internal capsule.
Okay, so not the big main roads, but like the really fine network feeding vital inner areas.
That's a pretty good analogy. And when these small vessels get blocked, the infarct, the area of damage, is typically small, often like 2 to 15 millimeters.
tiny.
Yeah, and these tiny infarcts leave behind these little cavities or lacunes in the brain tissue as the dead stuff gets reabsorbed.
Hence lacunar strokes, those little lake-like holes deep inside. So, key takeaway from your notes for the definition. Ischemic stroke. Small, penetrating arteries, deep structures, and these characteristic lacune infarcts. Got it. Clear foundation.
Good.
Now, why? Why does this happen? What's the underlying cause, the etiology, according to these notes?
Right, so shifting from what to why, the notes really emphasize that the primary reason these small arteries get blocked is something called small vessel disease.
Small vessel disease,
Yeah.
affecting those specific tiny arteries, and what drives that?
Well, your notes correctly link this back to common systemic issues, primarily hypertension.
High blood pressure.
Yeah, and other widespread vascular risk factors.
Yeah.
Basically, conditions that damage the delicate walls of these small vessels over time.
Okay, so the headline for etiology is small vessel disease, heavily driven by those standard vascular problems. The notes also mention other potential causes, right? Though less common.
Yes, they do. They mention possibilities like embolism, maybe a clot traveling from the heart, or bigger arteries, or vasculitis.
Inflammation of the vessels.
Right, or even some rare genetic disorders.
Hmm.
But honestly, for MSRE purposes, focusing on small vessel disease, secondary to those vascular risk factors, that's the highest yield point from your notes on etiology.
Got it. Small vessel disease, Angel's main cause, often due to vascular risks, which naturally leads us to who is most at risk. Your notes list specific risk factors. Let's run through them. What are they, and what's the key connection?
Well, the list is probably a familiar one if you're revising vascular medicine, and that's the crucial connection, really. These are overwhelmingly vascular risk factors.
They all feed into that small vessel disease picture.
Exactly. They
Yeah.
contribute to it.
Hypertension is usually number one, isn't it?
Absolutely. Chronic high blood pressure, it's a major culprit. It really damages those small arterial walls, contributing significantly to lipohyalunosis. We'll probably touch on that mechanism in a bit.
Okay. Diabetes mellitus.
Diabetes, yeah. It accelerates damage to blood vessels everywhere, including
Yeah.
these small brain ones. Makes them more vulnerable. Well-established cause of vascular damage, inflammation. No surprise there.
Hypercholesterolemia, high cholesterol.
Yep. It contributes to atherosclerosis, obviously. And while lacunar strokes are about small vessels, that same process of plaque buildup microtheroma, as your notes mentioned, can happen there too.
Right, even in the tiny ones. Obesity and a sedentary lifestyle.
These kind of contribute to that whole cluster of metabolic issues, don't they? They increase overall vascular risk, feeding into the small vessel problem.
And finally, a history of previous stroke, or TIA.
Yeah, if someone's already had a vascular event, it's a big red flag, isn't it?
Yeah.
It signals underlying vascular issues, making them susceptible to more events, including lacunar strokes.
So the absolute key insight here from your notes on risk factors is just how strongly they align with systemic vascular disease. It's not random. It's a direct consequence of factors damaging blood vessels, especially the small ones.
Exactly right. And understanding these risk factors helps explain the underlying pathophysiology, how the blockage actually happens at that cellular tissue level.
Okay, let's get into that. How do these risk factors actually cause the occlusion in those small penetrating arteries? According to your notes, what are the mechanisms?
Okay, so your notes pinpoint two key mechanisms happening inside the walls of these tiny vessels. The first is lipohyalinosis.
Lipohyalinosis, that sounds complex. What is it in simple terms?
It's basically a degenerative change in the vessel wall. Think of it like this. Chronic high blood pressure, for example, makes the vessel wall thicken up, become less flexible, almost glass-like, hyaline-like,
Right.
and fatty deposits build up within it. This whole process just severely narrows the channel inside the vessel.
So the small pipe itself gets thick, rigid, and kind of clogged from the inside.
That's a good way to put it. The second mechanism your notes mention is microtheroma formation.
Is that basically the same as the plaques in bigger arteries, just smaller?
Pretty much, yeah. Same process just happening in these tiny vessels. Small plaques, cholesterol, inflammatory cells building up. Even a small plaque in a tiny vessel can cause major narrowing or even block it completely.
What's fascinating here is seeing how these microscopic changes, the lipohyalinosis, the microtheroma, are the direct link between those big systemic risk factors, like hypertension, and the actual physical blockage.
Exactly. They disrupt the blood flow.
Leading to localized ischemia, lack of oxygen,
Lack of nutrients.
in that specific deep brain area supplied by that tiny vessel. And that lack of blood flow starves the tissue, it dies, and forms the infarct, the lacune. It's a chain reaction.
A chain reaction starting from damage to those small vessels.
Mm.
And these mechanisms really explain why lacunar strokes are distinct from, say, large vessel strokes, which are usually caused by big plaques or emboli from elsewhere.
That leads perfectly into the next crucial point for revision, differential diagnosis. If someone comes in with sudden neurological symptoms, how do you differentiate a potential lacunar stroke from other things it could be based on your notes?
Right. This is where the clinical picture and, crucially, imaging becomes so important. While lacunar syndromes have typical patterns, the symptoms can sometimes overlap. Your notes suggest differentiating from other stroke causes or mimics.
Like a stroke from a large artery blockage.
Yes, exactly.
Mm-hmm.
A blockage in a bigger artery, or maybe a clot that's traveled from the heart cardioembolism that can cause different patterns of damage. Often involves the cortex, leading to those cortical signs we mentioned.
Okay, so large vessel strokes might have things like aphasia or neglect, which lacunar strokes often lack. What else needs ruling out?
Well, you also need to think about things that mimic stroke, maybe a TIA, a transient ischemic attack where the blockage is temporary,
Wait.
or even non-vascular things, seizures, complicated migraines, metabolic problems that can cause temporary neurological deficits. And critically, you must use imaging to distinguish between ischemic stroke, like lacunar, and a hemorrhagic stroke, a bleed.
Because the management is totally different. You wouldn't give clot busters for a bleed.
Absolutely not. So, the clinical picture gives clues, but imaging is essential. It confirms it's ischemic, shows if it fits the lacunar pattern small, deep, and rules out hemorrhage or large vessel stuff.
Makes sense. Imaging is key. We'll get to investigations properly in a moment. But first, context. How common are these lacunar strokes? What do your notes say about epidemiology?
Yeah. I see a specific UK statistic in your notes here.
What does it say?
It says lacunar strokes account for about 25% of all ischemic strokes in the UK.
Wow, a quarter.
Yeah, so a significant chunk. Makes them pretty common.
That is substantial. And I assume the demographic trends mirror what we just talked about with risk factors.
Exactly. The notes say incidence rises with age, and they're more common in people with hypertension and those other vascular risk factors. It just reinforces that link again. Who gets them lines up perfectly with the causes and risks.
Okay, puts it in perspective. Common type, strongly linked to the usual vascular suspects. Now, the bit that's most visible, clinical presentation. What symptoms would you actually see? What did the notes say are the classic signs?
Well, the symptoms are highly variable because it really depends on which deep structure gets hit by that tiny infarct. But your notes list some classic high-yield lacunar syndromes.
Pure motor hemiparesis is a big one, right?
Absolutely, probably the most common. This is weakness, maybe paralysis, affecting one side face, arm, leg, but crucially, without major sensory loss, visual problems, or those cortical signs.
Your notes mention the clumsy hand example.
Yeah, or weakness mainly in one limb, like sudden difficulty gripping something or lifting an arm, but sensation feels normal.
Got it. Pure sensory stroke is another.
Yep, numbness, tingling, sometimes pain down one side, again, without other major deficits.
Ataxic hemiparesis is also listed here.
Right, that involves weakness and ataxia, lack of coordination on the same side. Someone might struggle with walking or fine movements because they're both weak and uncoordinated.
And dysarthria clumsy hand syndrome.
That combines slurred speech, difficulty articulating words, dysarthria, with that weakness or clumsiness in the hand on the opposite side.
Okay. The notes also mention occasionally seeing cognitive impairment or aphasia, but then they make a really key point about the absence of certain signs.
Yes, and this is a crucial distinguishing feature for revision. While you can see some cognitive issues, especially if someone has multiple lacunes over time, single lacunar strokes often lack those big cortical signs.
What?
Like significant aphasia, major language problems, or neglect where they ignore one side of space, or visual field cuts. If you see those prominent cortical signs, you should be thinking it's less likely a pure lacunar stroke, probably involves the cortex or subcortex from a larger artery issue.
So if a patient presents with sudden one-sided weakness, but their speech comprehension is good, they're aware of everything around them, that pattern really points you towards a lacunar syndrome based on these notes.
Precisely. These distinct syndromes, pure motor, pure sensory, ataxic hemiparesis, dysarthria clumsy hand, are the high-yield clinical pictures reflecting those deep infarcts.
All right. We've covered what it is, why, who's at risk, how it works pathologically, and what it looks like clinically. How do we actually confirm it and figure out the cause? Investigations. What's listed in your notes?
Okay, the absolute cornerstone for diagnosis is brain imaging. Your notes emphasize MRI or CT scans.
And what are they specifically looking for with the scan?
Well, imaging does a few critical things. First, it confirms it is an ischemic stroke. You see the infarct or reduced blood flow. Second, it visualizes the size and location. Seeing those small lacunes in the deep structures really supports the lacunar diagnosis.
And rules out other things.
Critically, yes. Rules out a brain hemorrhage or maybe a tumor mimicking symptoms.
So imaging, see the lacune, exclude bleeds. Your notes list other tests too.
They do. A full stroke workup usually includes blood tests, an ECG, maybe vascular imaging like carotid Dopplers or CT angiography.
But those aren't diagnosing the lacunar stroke itself.
Not primarily, no. They're more about assessing the underlying risk factors, checking cholesterol, blood sugar, looking for atrial fibrillation on the ECG, and searching for potential sources of emboli. Even though emboli are less common causes here, it's all about finding why it happened to prevent the next one.
That makes perfect sense. Deal with the acute event, but then dig into the why for long-term prevention. Speaking of which, management. How are lacunar strokes treated, both right away and long-term?
Your notes break it down nicely into acute and long-term strategies. In the acute phase, just like other ischemic strokes, things like thrombolytics, clot-busting drugs, or mechanical thrombectomies might be considered.
Might be.
Well, the notes seem to imply it's perhaps less commonly indicated or beneficial compared to large vessel strokes. Probably because the infarcts are so small and deep. The decision really depends on timing, symptom onset, patient factors.
Okay, so acute treatment options are there, but maybe used less often or with less dramatic effect than for bigger strokes. The real focus seems to be on long-term prevention.
Absolutely.
Yeah.
Because the root cause is usually that small vessel disease driven by vascular risks, long-term management is paramount. It's all about preventing recurrence. The notes list the core strategies. Aggressive control of risk factors.
So getting blood pressure down, managing diabetes, cholesterol.
Exactly. Tight blood pressure control is especially vital given that link between hypertension and lipofilinosis we talked about.
Right.
Quitting smoking, managing lipids, encouraging healthy diet, exercise. It's all the fundamental vascular health stuff.
And medication plays a role.
Yes. Your notes mention prescribing antiplatelet drugs like aspirin or clopidogrel, or sometimes anticoagulants, though less common unless an embolic source is suspected. It depends on the individual patient. The goal is just to make the blood less sticky, less likely to clot in those damaged vessels.
Okay, so acute options exist, but long-term risk factor modification and the right antiplatelet or anticoagulant therapy are the absolute key takeaways for management from your notes. What about the outlook, the prognosis? How does it compare?
Your notes indicate that, generally speaking, the prognosis for functional recovery after a single lacunar stroke is often seen as more favorable compared to strokes hitting larger vessels or the cortex.
It sounds encouraging.
It is. Because the infarcts are small and localized, significant recovery is possible.
That there's always a but.
Well, yeah. It's not always straightforward. Prognosis still varies depending on the lacune size and location, how fast treatment started, and crucially, how well those underlying vascular risks are managed going forward.
Which leads us straight to the potential long-term issues, complications. What lasting problems or future risks do your notes highlight?
Even if acute recovery is decent, potential long-term complications can include lasting motor or sensory problems, depending on where the infarct was. This can lead to ongoing functional limitations, difficulty with daily activities.
And recurrent strokes must be a big concern with that underlying vascular disease.
A huge concern. Someone who's had one is definitely at increased risk for another. Could be another lacunar stroke, could be a different type, especially if their risk factors aren't nailed down.
But there's another major complication mentioned. Something about cognition.
Yes, and this is really important. Your notes highlight the risk of cognitive impairment or even vascular dementia.
Ah. If we connect this to the bigger picture, a single lacune might cause a specific deficit. But if the underlying small vessel disease is bad, leading to multiple lacunes over time.
Exactly, especially in critical deep white matter tracts. Those cumulative small hits can really start to impact cognitive function significantly. Memory, processing speed, executive function.
So it's the buildup.
It's the buildup. This process, often called chronic small vessel disease or seen as leukorrhosis on MRI scans, underlines that increased risk of vascular dementia. Your notes correctly flag this as a major long-term worry, particularly with multiple lacunes.
Wow. Okay. So the picture emerging from your notes is, well, it's a specific type of stroke, often with clear syndromes, stemming from damage to small deep vessels, usually caused by those familiar vascular risks. The acute outlook can be relatively good.
Often, yes.
But the long-term risk, particularly for cognitive decline and more strokes, is pretty substantial if that underlying small vessel disease isn't aggressively managed.
That sums it up really well. That captures the essence of what your notes emphasize. It's a condition that really highlights the systemic impact of vascular risk factors right down to the brain's smallest pipes.
We've walked through the notes, hit all the key sections: definition, causes, risks, pathophysiology, differentials, epidemiology, clinical features, investigations, management, prognosis, and those complications. This deep dive should really help solidify those points for your revision.
Definitely. Understanding the nuances of lacunar stroke is vital. It's common, and the underlying pathology often gives you a window into the patient's whole vascular health picture.
It really does. And that long-term cognitive aspect adds another layer of importance to managing those risk factors diligently, doesn't it?
Absolutely. And, this raises an important question. Given that strong link between small vessel disease, multiple lacunes, and cognitive decline risk, how early and how aggressively should we really be targeting those vascular risk factors? Not just to stop the first stroke, but maybe to preserve long-term brain health and cognitive function down the line.
That's a really powerful thought to end on. It underscores that lifelong importance of vascular health.
It's something important to keep considering when managing these patients beyond the acute event.
Well, thank you for bringing your notes to this deep dive. We genuinely hope breaking them down like this has been helpful for your revision.
Our pleasure. And seriously, good luck with your studies.
And if you were specifically revising for the MSRA, remember there are other great resources out there.
Absolutely. Make sure you check out PassThemSRA.com.
And FreemsSRA.com.
Yep, both have a lot of materials, question banks, articles that could be really great complements to your notes as you prepare.
Definitely worth a look. Thanks, everyone, for joining us, and we'll catch you on the next deep dive.